Stigma around opioid use disorder creates barriers for people seeking treatment and access to care. At Del Seton Medical Center in Texas, clinicians observed that patients with opioid use disorder had a high likelihood of readmission because its underlying causes were not being addressed. As a result, Del Seton Medical Center developed what it calls the B Team to improve outcomes and reduce stigma that stands in the way of better care for patients with opioid use disorder. Welcome to Advancing Health, a podcast brought to you by the American Hospital Association. I'm Tom Hetterly, Senior Writer for AHA. In today's episode, Elisa Arispacochaga, Vice President of AHA's Physician Alliance, sits down with Richard Botner, an affiliate faculty member at Dell Medical School, to discuss how they have implemented an innovative treatment program to address opioid use disorder and reduce stigma.
Welcome to another podcast in the American Hospital Association's ongoing series where we focus on important issues facing clinician leaders. I'm Elisa Arispacochaga, Vice President of AHA's Physician Alliance, and today I'm joined by Richard Botner, affiliate faculty in the Department of Medicine at Dell Medical School and hospital medicine PA at Del Seton Medical Center at the University of Texas in Austin. And today we're talking about how hospital leaders can change the way they approach opioid use disorder. To get us started, Rich, start with a little bit about yourself and your experience as the director of the B Team, which has got to be my favorite name in healthcare.
Thanks so much for having me. I am a physician assistant and have practiced in hospital medicine for the past 5 years. But before going to PA school, my undergraduate education was in business and entrepreneurship, and I spent several years in that world. So I bring that experience with me to my clinical work. And so I'm extremely passionate about systems-based practice and working to improve the complex healthcare system that we have in the U.S. And so in the context of our discussion today, I've been the director of the buprenorphine team, or the B Team, for the last 2.5 years or so. And that is a interprofessional and multidisciplinary group that works to screen patients for opioid use disorder who are admitted to the hospital, initiate buprenorphine therapy for patients who are interested, follows them and supports them throughout hospitalization, and then links them to care prior to discharge, what I call the boiling hot handoff, not the warm handoff. And then equally important, providing a large amount of institutional education and stigma reduction around not just OUD, but substance use disorders as a whole.
So can you tell us a little bit of the history? How did you and the entire organization really recognize the need to change the way you approached treating opioid use disorder and substance use disorder in general, particularly on the inpatient side?
I'm not sure that we actually did recognize it early on. And I think it's important to recognize that our society in many ways and our healthcare system has a lot of stigma around substance use disorders and patients with substance use disorders. And that stigma in a number of ways creates barriers for those patients being able to access care. And I say that because I had that mindset myself when we started this work. And so when we started it 3 years ago, it was really around quality improvement specific to readmission. So we were looking at readmission data. We found that patients with opioid use disorder had high likelihoods of being readmitted to the medicine service. So not in the emergency room. These are patients who are being admitted to the hospital to internal medicine. And the readmissions were not, necessarily related to opioid poisonings or overdoses. These were for endocarditis and skin and soft tissue infections and epidural abscesses and those sorts of things. Buprenorphine was already on our formulary, but we realized that really nobody knew how to use it or when to use it. And so we would have these cycles of readmissions. And as we often say, we would put air in the tire. We would diagnose and fix the admitting reason that the patient was presenting without ever finding the nail and patching the tire in the first place, without ever treating the underlying problem, which is the opioid use disorder. So we started doing this to reduce readmissions. But I think we recognized very early on in doing this that offering an evidence-based, cost-effective, life-saving medication to patients was the absolute right thing to do for our patients and our staff and our hospital and our community. And now I look back on it and I think, how have we been practicing for so long without this as our standard of care? And then I get sort of sad knowing that, there's 6,000 hospitals in the country and the vast majority don't have this type of setup. We are the only hospital in the state of Texas that does this kind of work, and there are pockets around the country of other hospitals, but really this is the exception today, not the rule. Despite knowing that, for patients who use heroin, for example, 80% of those patients will go back to using again within 30 days of discharge if they're not provided appropriate resources and treatment. And I want to offer an important clarification that this is not an addiction medicine consult service. This is a very targeted intervention for a very specific patient population, and one that, can be and should be accomplished by primary care teams of the hospital. So for us, this is our standard of care. And the example that I like to use is comparing this to diabetes, in the sense that if a patient has diabetes and is admitted for severe hyperglycemia, even if it's their third admission for that same thing in the last month, we still provide counseling. We still provide an evidence-based and cost-effective medication in the hospital and at discharge. And often we facilitate that outpatient follow-up for the patient as well. And so OUD is a chronic medical disease, and we should be doing the same thing for those patients as well.
Yeah, it sounds like you started looking at one problem and then realized you had a completely different problem to solve underneath it. It sounds like the B team really helped identify where the challenge really was. So what have you noticed about the outcomes over the last 3 years or so of these efforts? In addition to, and I know you've had some great outcomes in terms of the patients you've been able to help, but I know you've had some other outcomes that I don't know that you thought about in that initial work.
Yes, absolutely. So from a patient perspective, which is the most important one, patients with OUD are so incredibly appreciative that we offer this program and this service. And it's really not about the medication, it's about what the medication represents. It's destigmatizing substance use and opioid use disorders in the hospital and helping patients faced with addiction. And these patients historically have been treated poorly by the healthcare system and society at large. Nobody wants to be a patient in a hospital. And for these patients, that is largely amplified by the very many bad experiences that they may have had and being labeled as, quote unquote, drug seeking or frequent flyers or other derogatory terms. And so from a stigma perspective, patients really appreciate the work that we're doing. From a clinical perspective, our 1-week follow-up rate when we looked at our data last was about 60%. So when patients leave the hospital and we make that appointment for them at the community clinic where they can continue in substance use treatment, 60% of patients are making it to that appointment. So clearly many of our patients are trying, and it's important that we are sensitive around patient-centered outcomes here. And I say that because when you look at many of the addiction-related studies and when we talk about a lot of the common primary endpoints as a healthcare system and as a hospital, we often look at mortality. But when we talk to patients in the hospital, they often don't. They talk about not wanting to feel sick all of the time. They talk about wanting housing, wanting employment, potentially getting their children back from CPS. They really talk about quality of life. And we haven't figured out great ways of studying that long term, but it's very clear that the quality of life or the patient experience aspect, if you will, in the hospital can be very positively impacted by meeting patients where they're at and having a mechanism to facilitate patients entering or continuing that journey to recovery. And to your point, another piece here is staff satisfaction. So the degree to which prescribers and nurses and others on the care team have frustration around seeing patients frequently with this life-limiting disease and not having tools in their tool belt to help is a very distressing feeling for people who work in healthcare. And so now there is something that we can do. There is something that we can offer. But before we do that, we have to reduce that stigma, and we have to help our healthcare teams understand and appreciate that addiction is a chronic medical illness, just like many of the other things that we treat in the hospital.
Absolutely. And I know you've changed a lot of minds in your medical center with this work. As you were talking to your leadership and pushing this forward, what were some of the reasons of, sort of how and why you think hospitals really should be looking at ways to support this type of effort where they're really changing the way you think about and treat substance use disorder?
It's a great question. I think we've spent a lot of time and energy in the U.S. talking about appropriate prescribing of opioids. And hospitals, in a lot of ways, have been leaders in those conversations. We've tried very hard to develop processes where most patients do not receive high quantities or high doses of opioids in the hospital or at discharge. And that work is obviously important, but we have really failed to balance that with resource development and allocation around treatment and harm reduction. And so the consequence of that is the sort of off-market supply of legal opioids began to tighten, and that may have inadvertently pushed patients towards things like heroin and fentanyl. And that's very dangerous from an opioid poisoning perspective, but now we're also talking about consequences of intravenous drug use, like hepatitis C and HIV, which are lifelong and often result in other disease processes that require lengthy hospitalization. That was a very key message for us with our hospital leadership is our institution had done a tremendous amount of work around appropriate prescribing, but like most other institutions had not done that balancing work. And I think we tried really hard to message the importance of doing that. And I want to be clear that, I am not advocating for hospitals to become treatment centers for substance use disorders. We need to do a much better job at building those systems of care in the outpatient community. But hospitalization is often described in our line of work as being this sort of reachable and teachable moment. So patients are removed from an environment that may be triggering, and they're surrounded by this hopefully caring and supportive staff. It's such an ideal and wonderful moment to try and help them. And even if we're not successful in starting a patient on buprenorphine, for example, there's a major role for harm reduction, things like naloxone distribution. And I think we can also make the argument at this point that this work is cost saving for the institution, specifically in terms of readmissions, but I think also in terms of length of stay and total cost of care, et cetera. And so you asked how leaders can support this and how hospitals can support leaders with interest in this. And that's a very important question. We don't know what we don't know. And as I mentioned earlier, we had no idea the kind of positive ripple effect that this program would ultimately have. And early on, it was our executives and our department leaders who supported us going on this, somewhat uncharted path and journey, and we would not have been able to do it without their support. So at the end of the day, that's what hospitals need to do. They need to be open-minded and receptive to new ways of thinking about substance use disorders within the hospital setting. And quite honestly, the lack of that open-mindedness is what got our country into this in the first place. Not specific to hospitals, but our healthcare system as a whole.
Absolutely. We've talked extensively about the impact that stigma has had on further reducing the ability to reach patients. I think there's a lot of value in being able to normalize treating opioid use and substance use in the same way that you've normalized treating every other medical issue that you've faced in your practice. And so I think that just being able to help your entire organization see the B team as another consult in the list of consults, as you referenced earlier, similar to the way that they would consult an endocrinologist for someone with diabetes. So I love that you've been able to make this change. And I don't know that it was one you thought of going in, but it's really made a difference, it sounds like, at your organization. So since nothing comes out perfect, out of the gate, What would you do differently if you had this to start over and, go back 3 years ago? What would you, couple of things you might not do or do in a different way?
Yeah, it's interesting because you were just mentioning the benefit of having this as a consult service, and hindsight's always 2020, and I would say that setting this up in the model that we did presented us with some challenges, and so we set this up as a interprofessional consultation service driven by volunteers, and that was extremely helpful early on to develop and establish subject matter expertise within the institution. But the goal was always to shift the culture and teach people about this and then stop doing it as a consult service because everybody would just be doing this on their own. Mm-hmm. And so I'm a science geek. So my loose analogy for all of this is that our team would be like macrophages and we would slowly gobble up everyone in the hospital. So that all of the primary teams and all of the nurses and all of the social workers and all the pharmacists, et cetera, were part of the team and the team was part of everyone. And because, again, the goal is to shift the standard of care around how we treat OUD, and buprenorphine is, of course, a part of that. And so that's been happening, but probably at a slower rate than what we imagined. And we're an academic center, so we really want the trainees learning how to do this so that when they graduate, they take this knowledge with them elsewhere. But as we all know, it's much easier to call a consultant to do something than it is to kind of do it on our own. So we're in the process now of moving into, phase 2, if you will, which is where we will be requiring essentially increased participation from the resident teams. But I really anticipate that being a non-issue since those teams have been working alongside us now for many, many months and have a strong interest in learning more.
That's great. So to wrap up our conversation, I'd love to hear maybe some learnings or advice you'd give folks who want to change the way their own organizations really approach substance use disorders. And if somebody wanted to launch a program like yours, besides calling you to walk them through it, what are some key takeaways or advice you'd give?
First, anyone who is listening, who is interested in doing this work at their institution is more than welcome to call me anytime. I am very passionate about this work, as is the rest of our team. And really, our goal is to encourage other hospitals to do this sort of work. So I'm always available for that conversation. But I guess what I would start by saying is when I reflect on the last several years, I think about how I was part of the problem. And I had a fairly narrow viewpoint on many of these patients and what I felt I could offer them as a clinician. And I'm in a certain type of recovery myself from all of the stigma and preconceived notions that I had based on my life experience and my healthcare training. And so I think it's really important that we recognize that addiction in our country and substance use disorders and the potential role of the hospital really goes far beyond just opioids. And there's a lot of historical and sort of socio-political reasons that opioids are the, hot subject of the day, if you will. But we also have major problems with alcohol and cocaine and methamphetamine and tobacco. And these issues are incredibly complicated. And the more I peel the onion, the more I sort of tear up with my own frustration of how we got here as a country. But the more I feel motivated to push for change, and the more that we push for that change at our own institution, and we've started doing some advocacy type work in our state, the more we really start to see the benefit of that work trickle down to our patients. And so I think the first thing is recognizing where we as individual practitioners have biases, and then where we as leaders have biases, and then where we as institutions and healthcare systems have more of a structural bias, if you will. 2, which really should have been 1, I think, is the team. I'm speaking with you today about this program while an absolutely amazing team of hardworking and exceptional nurses and social workers and chaplains and pharmacists and psychiatrists and internists are working clinically as part of this team to fix this issue. No one person and no one discipline in a hospital is going to fix this. It is a team effort. And I've had a good number of hospital executives say to me over the last several years, I can't start this in my institution because I don't have the right people who are expressing interest. And again, I'll go back to stigma. Those people are in every hospital waiting for the opportunity, but most are not going to independently push for this kind of work because that stigma is so strong. So we could not do our work at all if we didn't do it as a team. And this is a group where everyone has a voice and we work together to develop solutions to complicated problems, but solutions that ultimately benefit our patients and our institution and our staff. And then probably the last one, which I know I've mentioned several times today, is that stigma. The stigma around substance use disorders specifically is so pervasive, and it's so toxic to continuing to make progress in systems of care for these patients and developing those systems. The idea that addiction is a moral failing, or that buprenorphine is, replacing one addiction with another, all these notions, really just create barriers to efficient and effective care. So knowledge is power, and developing this expertise over the last several years has allowed myself and our team to really change the hearts and minds of those that we work with. And I think that's ultimately how we change the system. One patient, one practitioner, one administrator, one hospital at a time.
Absolutely. I remember hearing a presentation where a physician was talking about how very much they enjoyed treating their patients who they were supporting on buprenorphine, because these were patients who very visibly see the change they had brought to their lives. And some of the stories that they had really brought them back to why they entered medicine. And I'm sure you have a number of those as well. But thank you for everything you do to help your patients. And for more details on the program at Del Seton, Rich is doing a webinar for us that'll be available with this podcast, along with resources addressing stigma on the AHA's website at aha.org/opioids. So Rich, thank you so much for all of the time and effort you've put into your own work, and then your generosity in sharing it with our audience and continuing to support teams across the country in doing this work.
Thanks so much for having me.